Hello everyone, welcome to Scan 2030 HEOR 101 lecture series. I'm Shirley Li, Assistant Professor from Lee Kai-Sing Faculty of Medicine, the University of Hong Kong. I'm also the Project Coordinator of Scan 2030. Today we're going to talk about how does health economic evaluation help to allocate healthcare resources. The learning objective of today including understand why health economic evaluation is essential for resource allocation decisions, know the principles of health economic study design, and know how to interpret the results from typical health economic studies. You will also gain some insights into shared decision-making from multiple stakeholder perspectives. Economics is about the choices in the scarcity of resources. There are three ways to address the scarcity issues. First is the economic growth. Second is to reduce the care needs. And third is efficiently use of current resources. It is always not easy to generate economic growth quickly, and it is not always not possible to remove the care needs. What we can do is to make good use of available resources to efficiently allocate services and treatment to maximize societal benefits as a whole. Resource allocation in healthcare faces two kinds of dilemma. The first is there has been increasing number of approval innovative therapies, but their cost when hitting the market are also increasing. With scarce resources, how do we know which drugs have a cost that are justifiable by their health benefits? Which one has high value for money to be included in our formulary or reimbursement plans? The second dilemma is drugs for patients with rare diseases. Those orphan drugs often come with high cost because of the R&D expenses, but the number of patients who benefit is limited. Should we allocate resources to treat these patients at an opportunity cost of treating those with common conditions? Health economics is the science designed to deal with such dilemma. It is a possible way to inform the economic value of treatments, interventions, or programs. There are three features of health economic study. The first, we must involve the comparison of two alternatives. Second, we must consider both costs as the inputs and the benefits as the outputs of alternatives. And lastly, we must combine cost and benefits into one indicator for informed decision-making. There are three common types of economic evaluation, including cost effectiveness analysis, called CEA, cost utility analysis, we call it CUA, and cost benefit analysis, we call it CBA. In the following lectures, I'm going to elaborate these three types of economic evaluation in detail. The first type of economic evaluation is cost effectiveness analysis. In CEA, we measure the cost required to achieve unit gain of a natural health unit. Examples of natural health outcome include number of deaths avoided, gain in life years, percentage reduction in blood pressure, etc., etc. We will elaborate the concept of CEA using an alcohol control example. Systematic review suggested that alcohol consumption is reduced by 20% following a brief intervention among drinkers. In a hypothetical at-risk population, it translates to 6 alcohol units reduction per person per week. The policymakers is facing a problem that what is the cost effectiveness of brief intervention compared to do nothing among general population? To investigate this, we will run a clinical trial. The brief intervention group will involve the cost related to the questionnaire-based screening for 100 people, which is equals to $480. Upon the screening, assuming we identified 36 people at risk, then we will provide brief intervention for those 36 people. associated with an intervention cost of $720. Therefore, the total program cost will be $1,200, and the intervention cost per drinker will be around $33. Comparing to do nothing, we already know that additional benefits of this brief intervention program would be 6.0 alcohol units reduction per drinker. Combining the cost and the benefits as one indicator as incremental cost-effectiveness ratio would give us an ICER value of $4.6 unit reduction in alcohol consumption. It means that comparing with doing nothing, we need to pay $5.6 more to reduce 1 unit of alcohol consumption among general population. The advantage of CEA is it is quite straightforward and easy to calculate. While the downside of CEA is that it may not reflect the wider benefits outside the natural health unit, it is also unable to examine other types of interventions that are not specific to alcohol reduction. The second type of economic evaluation is cost utility analysis. It is also the most widely used health economic evaluation in the current literature. Cost utility analysis is based on the concept of opportunity cost, which is the opportunities to do different things are lost when the resources are committed to other purposes. With respect to this, the comparison of a decision requires a common outcome measure that incorporates quantity and quality of life changes, because some treatment may improve both aspects, but some may only affect the length or quality of life. So to be able to make a fair comparison, we need a common outcome measures. Recall the concept of quality from what we learned in previous HEOR 101 lectures. Utility is a value set that translates health states into a numerical value indicating the quality of life between perfect health and death. Quality adjusted life years, QALY, is the outcome measures that incorporate length of life and quality of life, which could act as the common outcome measures for direct comparison. Let's going back to the example about alcohol control. Now we have two options. Option A, using the brief intervention to reduce alcohol drinking. The option B is prescribing drug B to treat alcohol-related liver diseases. Which one is more cost-effective? Upon the clinical trial results, option A will cost more than $70,000 per year with an expected 281 QALY gained per year. While option B is associated with an annual cost of over $44,000 with 160 QALY gained. The incremental cost utility ratio of option A in comparison with option B is $150 per QALY gained, meaning that treatment A will cost $150 more to save 1 additional QALY. ICER values such as 5.6 per unit alcohol reduction and 150 per QALY gained are too abstract. They are only meaningful when we put them into the cost effectiveness plane and compare them against a threshold. Willingness to pay threshold is usually presented as the slope in the cost effectiveness plane. It represents the maximum acceptable level of cost per effectiveness yield. It could be individual-based or population-based. Its determination relies on the reference to a local standard. In reality, you will find most of the ICERs fall in the first quadrant of this cost-effectiveness plane, meaning the new treatment will offer more health benefits with higher cost at the same time. Options with the ICER below the willingness to pay threshold will be considered cost-effective in comparison with the reference group in the local context. The third type of economic evaluation is cost-benefit analysis. In CBA, health benefits are measured in monetary terms. CBA is useful when there are a wide range of health benefits associated with treatments being evaluated. It can determine whether the money value of benefits outweighs the cost. Let's have a look at our example about alcohol control again. Same as previous scenario, we are comparing preventive option A versus curative option B for alcohol-related disease control. Health benefits associated with option A and B have been estimated respectively by translating the costs saved into management values. Using option B as the reference, we can calculate the incremental net monitoring benefits associated with option A, resulting in additional benefits of more than $142,000, meaning that implement option A will return a positive monitoring benefit. Although CBA would give us a very straightforward results in terms of monitoring benefit, there are ongoing debates about how to value the life and whether people from all folks should be treated equally with similar value for life. This slide shows a quick summary of CEA, CUA, and CBA concepts and their advantages and drawbacks and how they should be used to complement each other. There are also some additional points worth to note. For all types of economic evaluation, we need to know whose perspective we stand for. From patient's perspective, out-of-pocket treatment cost, caregiver cost, traveling time, and the productivity lost should be considered from the costing components. From healthcare payers' perspective, we should consider manpower cost, drug acquisition cost, and overhead cost. From societal perspective, we should include all opportunity costs such as psychiatric care, medical care, legal and family resources, all into consideration. The second note is about can CEA, CUA, and CBA indicate the sustainability and equality of healthcare system? A simple answer is no. They are useful, but not enough. Budget impact analysis could provide direct funding indication to the healthcare system for sustainability issues. And even more important, value for money assessment is not the only criteria for healthcare resource allocation. Clinical factors such as safety, efficacy, and quality are always the preconditions for decision-making. Economic factors casting significant indications for the disease burden and the value for money aspects, while health equity and the patient voice are also the essential and unneglectable factors in the decision-making pathway. That's all for this session. Thank you very much for your listening. We look forward to seeing you in the following HEOR 101 lectures.